My topic is on COVID-19 vaccine immunogenicity and implications. So my talk will reveal the vaccine effectiveness and booster based on local and overseas data, and the impact of variants of concern on this immunogenicity. So currently there are quite a number of variants of concern circulating around. Of course, Omicron is the most variant of concern. So we have a fair bit of cases in the fifth wave due to Omicron. BA.1 and then BA.2 became the main circulating variant. And recently we also had BA.2.12.1 and also some BA.4, BA.5. So all these VOC actually can increase transmissibility and reduce vaccine effectiveness. If we look at the Omicron subvariants, so the BA.2, BA.2.12.1, BA.4, BA.5, etc., all these increased transmission potential with higher immune escape. And according to the information submitted to GZ recently, BA.2 represents 39%, while BA.2.12.1, BA.5, BA.4 represent 28%, 6%, and 3% respectively. Now, currently there are two vaccines available in Hong Kong. So the Pfizer-BioNTech vaccine, when it first came out, the data showed that there was actually a vaccine effectiveness of 95% against symptomatic infection, against the wild type virus, of course. And then we also have the Sinovac or CoronaVac. When the dose interval was separated only for 14 days between the first two doses, the vaccine effectiveness was only around 51%. However, if you spread out the dose interval between the two doses to 21 to 28 days, the vaccine effectiveness actually increased to about 62% against the wild type. But there are two ways that the SARS-CoV-2 vaccine can protect us. One is through the B-cell function, humoral response, protecting us against symptomatic infection. And then we also have the T-cell response, which prevents severe disease, hospitalization, and death once we get infected. The problem is immunity waning. There are data from mainland China showing that after 2 doses of CoronaVac, basically the neutralizing antibody level dropped quite quickly over about 6 to 8 months in most people. And even with the Pfizer-BioNTech, data from Israel have shown that about 16% will have a drop of antibody below 50 AU per mil after about 6 months. So here are some data on the healthcare workers vaccinated with BioNTech. They were tested monthly for the presence of anti-spike IgG and also neutralizing antibody in Israel. So you can see from the left upper corner that the IgG actually decreased at a constant rate, while the neutralizing antibody decreased rapidly for the first 3 months and then with a relatively slow decrease thereafter. And then 6 months after receipt of the second dose of BioNTech, antibody levels actually became lower among men than women. So you can see in the bottom figure. And also among people aged 65 years plus, the antibody level also is lower compared to those aged 18 to 45 years. And the antibody also became lower among people who are immunocompromised than those without immunosuppression. So this factor we need to take into consideration. So here are data from the US showing that the vaccine effectiveness against symptomatic infection actually reduced over the next 5 months or so. So the top part A is actually the B-cell response. And then the vaccine effectiveness against hospitalization, which is a T-cell response, actually remained quite steady with time, over about 5 months or so. But overall, you can see from the data that the vaccine effectiveness actually was lower in the older age groups, and also with the emergence of variants of concern with time. And even in the children and adolescent population during Omicron predominance, vaccine effectiveness also dropped. So among children 5 to 11 years, the VE was about 60% 2 to 4 weeks after the dose 2, and then dropped to about 29% about 2 months after the second dose. And then among the adolescents aged 12 to 15, the estimated VE was about 60% 2 to 4 weeks after the second dose, but it dropped to about 17% during month 2. And then after a booster dose, the estimated VE actually increased to about 71%. Okay, so a booster dose would still be important for the adolescents, and also, of course, adults. So the emergence of Omicron raised more problem. The immune evasion is actually more marked compared to other variants. So you can see even with the different types of platform, the VE all became reduced, more so for the inactivated vaccine compared to mRNA vaccine. We have also looked at the antibody level 1 month after the second dose of vaccination, comparing BioNTech and CoronaVac. So we actually have an age-matched study. If you look at the figure A, there were two groups. Of course, the BNT antibody level in terms of SVNT was a lot higher compared to CoronaVac. But then the CoronaVac recipients were older. So that's why we actually did an age-matched study. So data from B onward is age-matched, about 51 years. And you can see the PRNT titers actually was a lot higher among those who received BioNTech compared to CoronaVac. And even if we change to ELISA to look at the like other parts of the virus, like you can see that the RBD, NTD, and S2, the antibody level actually is still higher in the BNT compared to CoronaVac. So we have this study ongoing. We noticed that many of the CoronaVac recipients actually had the SVNT below 60% inhibition, about 1 month after the second dose. So we actually randomized them to receive a booster dose. So half of them received BioNTech, and half of them continue to receive CoronaVac as the third dose. So you can see the result on the left-hand side. Before the third dose, both groups had actually very low SVNT level. Okay, they received 2 doses of CoronaVac. And then 1 month after the third dose, you can see that the SVNT shot up in those who received BNT. While those who received CoronaVac for the third dose, they had a rather variable response in terms of the SVNT. So basically, the BioNTech booster dose for those who poorly responded to the previous vaccination of CoronaVac is more immunogenic compared to the CoronaVac booster. And on the in vitro study, BioNTech also elicits higher level of SARS-CoV specific neutralizing antibody to different variants of concern. So you can see the wild type beta, gamma, and delta on the right-hand side. The CCB group actually had much higher SVNT level. In terms of side effects, those who switch to BNT for the third dose, they would have more side effects in terms of injection site pain, and also the fatigue and muscle pain compared to those who continue to receive CoronaVac for the third dose. Kuori actually estimated that the correlate of 50% protection from reinfection was about 20% of the convalescent neutralizing antibody titer after reviewing a large volume of literature. If we convert this to the PRNT 50 titer, this would actually correspond to a titer of 1 in 26 as the 50% protection threshold from reinfection. So 1 in 26. Now, when we look at the virus neutralizing titer against the wild type original SARS-CoV-2, the 2 vaccines in Hong Kong actually work very well. So even with 2 doses of BioNTech or CoronaVac, you would meet the threshold, the protective threshold of 1 in 26. Okay, but of course, if you have 3 doses, you would actually do better with a higher PRNT 50. Okay, so if you have 2 doses of CoronaVac and then you switch to BNT, again, you also had high level. So basically, if we are talking about the wild type, the two vaccines in Hong Kong are actually equally useful. Or if you have already acquired infection and you have only one dose of either BNT or CoronaVac, you still have very high level in terms of the neutralizing antibody titer. But that is wild type, which has long gone. Now, when we turn to Omicron BA.1, 2 doses of BNT or CoronaVac would not meet the protective threshold. So you need to have 3 doses of either BNT or CoronaVac. Even CoronaVac is very marginal. You can see it's actually just marginally touched the protective threshold for severe disease. But in terms of symptomatic infection, it is actually below. And then, but if you have 2 doses of CoronaVac and then switch to BNT, then your PRNT level is actually higher than the protective threshold. Okay, and if you have recovered from SARS-CoV infection and received 1 dose of BNT, you also have very high level against BA.1. And recently, we also look at the similar data against BA.2, quite similar, okay? So you need to have 3 doses of BNT to achieve the protective threshold, or if you have received 2 doses of CoronaVac and then switch to BNT, you also meet the protective threshold. If you have recovered from SARS-CoV-2 and then receive 1 dose of BNT, you also have very good level. Now, Omicron in unvaccinated people can only induce very weak antibody response. So the data in blue and orange represent breakthrough infections. So these people are fully vaccinated, and then they actually had the infection, and they actually had very high antibody level. But if you only had, if you're unvaccinated and then became infected, antibody level is actually very weak. Okay, and more importantly, the antibody response in the vaccinated individuals is broadly reactive, and it can also react with other VOCs such as beta and delta. So if you have Omicron infection and also fully vaccinated, you actually can cross-protect against other variants. Recently, we also look at the T-cell response against SARS-CoV-2 using flow cytometry, using peptide pools of wild type or Omicron 1 month after the last dose. So if you focus on the figure A, you can see that the 2 doses of either CoronaVac or BNT could actually elicit significant increases in specific CD4 and CD8 response compared to the pre-vaccinated control. The vaccine-induced T-cell responses to the wild type and Omicron generally were comparable between the 2 doses, the two vaccines. But BNT relatively induced more potent spike-specific CD4 and CD8 T cells compared to CoronaVac. If we look at adults aged 60 years plus who received CoronaVac, they actually show significantly lower number of SARS-CoV-2 specific T cells compared to those who received BNT. So this is T cell response. And we also look at the 3rd dose of either BNT or CoronaVac. The 3rd dose of either vaccine actually could boost waning T cell responses compared to the pre-3rd dose levels, but the level did not exceed those seen 1 month after the 2nd dose. So a booster is important to boost the T cell response. Now here are real data actually in Hong Kong. This study was actually done by our colleagues in Hong Kong U. Well, basically you can see in the bottom part that 3 doses of either BNT or CoronaVac have comparable VE against severe or fatal disease. This is a good reflection of T cell functions. So 3 doses of either vaccine could do the job. However, if you look at 1 dose or 2 doses, BNT appear to do a bit better, especially among the older age group. BNT actually produced a slightly better response, but 3 doses were comparable. In Israel, they have also compared 3 doses against 2 doses, and they have shown that 12 days after the 3rd dose, the rate of confirmed infection was lower in the booster group compared to the 2 doses group by a factor of 11, and the rate of severe illness was lower by a factor of almost 20 in those who received 3 doses of BioNTech. And here are also data from Qatar showing that vaccination enhanced protection against BA.1 or BA.2 among people who had had a previous infection with variants after Omicron. So you can see the data. The hybrid immunity actually is important. It results from previous infection and recent booster vaccination, and that would actually confer the strongest protection. Okay? So you can see the data, 3 doses of vaccine plus previous infection with variant other than Omicron could actually offer the best protection against BA.1 or BA.2. Now, however, the vaccine effect against symptomatic Omicron infection wanes with time after vaccination with 2 or 3 doses of mRNA vaccine. So you can see the drop is actually very apparent after 2 doses over about 6 months. And even after the 3rd dose, in subsequent months, the VE also dropped. So the immune escape is actually quite bad with Omicron. And then there are data from the USA showing the waning of VE against hospitalization due to Omicron 9 months after the 2nd dose. So this is a T-cell response. So T-cell response also would drop with time. However, 3 doses of BNT confer high protection against hospitalization and A&E admission due to both variants, BA.1 or BA.2. But waning was apparent against SARS-CoV-2 outcome, especially due to the Omicron variant. So additional doses of the current or novel vaccine would be needed to protect against subsequent waves caused by Omicron variant or future variants with similar escape potential. So here, data from Israel on the 4th dose showing that it was effective in reducing the short-term risk of COVID-19 related outcomes among persons who had received a 3rd dose at least 4 months earlier. So if you look at A to E, all the parameters show the separation. So the 4-dose group did better. And then we also have data from Israel in an open label non-RCT among healthcare workers. So the 4th dose was given 4 months after the 3rd dose. And basically after the 4th dose, BioNTech or the other mRNA vaccine, Moderna, could actually induce IgG antibody against SARS-CoV-2 RBD by a factor of 9 to 10 to titers that were slightly higher than those achieved after the 3rd dose. And both vaccines could actually induce an increase in neutralizing of the Omicron variant and other viral strains by a factor of 10. And the 4th dose did not lead to substantial adverse events. So this is another study from Israel published in BMJ lately, showing that the relative effectiveness of the 4th dose of BNT compared with a 3rd dose against SARS-CoV-2 infection. And that wanes sooner than the relative effectiveness of previous doses. So the 4th dose effect actually, in terms of antibody response, is quite short-lived, maybe lasting for about 2 months. And the relative effectiveness of the 4th dose against severe COVID stay at a high level. So this is a T-cell response, okay, after the 4th dose. So it remains quite strong in terms of the VE against severe infection. But by the 5th week of the vaccination, the VE of the 4th dose against symptomatic infection actually dropped back to levels similar to those observed during the 1st week. So here are actually more data from Israel also. The adjusted rate of severe COVID-19 in the 4th week after receipt of the 4th dose was lower than that in the 3-dose group by about 3.5-fold. And there was protection against severe illness, which did not wane during the 6 weeks. So that is a T-cell response. And the adjusted rate of confirmed infection in the 4th week after receipt of the 4th dose was lower than the 3-dose group by a factor of about 2. But this waned in later weeks, and that is a P-cell response. If we look at the Hong Kong data, currently we have about 93% of the population that have received 1 dose, and about 88% that have received 2 doses. For the 3 dose, we only have about 62% of the population receiving 3 doses. So we are a bit behind Singapore in terms of the third dose, but we have already built up a certain degree of immune defense in the community. So we can see from the HA data that the number of critical and severe cases is below 30, basically, in all hospitals. And there are very few fatal cases these days. So here data showing that the people who died usually are those who received 0 to 1 dose of vaccine only. Okay? And they are predominantly the elderly, aged 70 years plus, especially those 80 years plus. So about 88% receive either 0 or 1 dose, and they die. And this is the vaccination rate among the different age groups. So currently the elderly, 80 years plus, 68% receive 1 dose. And about just slightly over 60% have received 2 doses. So really we have to speed up the vaccination program for this high-risk group. And there are also priority groups that could receive the booster dose, and these are the immunocompromised patients, those who have cancer, transplant recipients, immunodeficiency, HIV, or receiving immunosuppressive. So the 4th dose is also available for people aged 60 years plus, and also the others aged 12 years plus with immunocompromised condition, and also high exposure risk group. So in summary, the emergence of more transmissible VOC has led to increased hospitalization, reinfection, and compromised vaccine effectiveness. Unvaccinated individuals, they are the key driver for the current wave of the pandemic. BioNTech is more immunogenic for humoral response, offer better short-term protection against infection as a booster compared to CoronaVac. However, 3 doses of either vaccine are equally effective in reducing risk of hospitalization, severe disease, and death. And currently, the 4th dose is available to the high-risk subjects. I think in the future, we need to have additional doses of current, adapted, or novel COVID vaccines in order to maintain high levels of protection against subsequent waves of SARS-CoV-2 caused by the Omicron subvariant or other future variants with similar escape potential. So finally, I would like to thank all my collaborators. Thank you.